To Dr. Gaurav Luthra, whom we all know is really a fantastic surgeon based out of Dehradun, Drishti, and he'll be talking about pupil and iris issues, expanders, and reconstruction. Over to Gaurav. Thanks.
Thank you so much, Dr. Mahipal sir, for making me part of this course, and very good morning to everyone. I'll try to share a few videos of my surgeries. This is a 22-year-old man who had injury with a wooden stick a few 2 years back, presented with iris prolapse and a perforation, was primarily repaired by another surgeon, and a tissue iris abscission was done, and then it was sutured. So this was the primary repair, and then this patient went on to develop a cataract. It was a rosette kind of a cataract, it's a traumatic cataract, and eventually needed a surgery, but there was a big iris defect, and you can see that there was loss of iris tissue where the abscission had been done, but there was also a big sphincteric tear. So my first instinct was to think about doing a single pass fourth row pupiloplasty and join these two areas here, and which would have been fairly easy to do, but this would have drawn the pupil a little bit this side. This defect seemed to be a little too big, and it was probably going to need something else. So what we decided to do was, we obviously planned for a cataract surgery, noticed that there was symmetric astigmatism, and we tried to design a ring which would have a prosthetic part to it, and these can be customized, and we got several designs made, trying to see what kind of a design to put there. And when we finally went through with the surgery, we had three different rings, one for 180 degrees and another one for about 120 degrees, trying to see what would bridge this defect. So once we started, the cataract part was fairly straightforward. And the cataract was out in a few seconds. It's a soft cataract, and then implanted the lens. It was a toric lens which we implanted. Now there was a dilemma in the mind, because first thing is, these implants, they require a slightly bigger incision than the 2.2 which we are used to, so you have to increase it to about 3.5, otherwise they don't go, and they are brittle and friable. Also, there are concerns about loss of pigment, but I've had a few of these patients over the last 10-15 years now, and most of them have done well. There have been improvements in these. Of course, Morsher makes these implants as well, but they're very, very expensive. So with no financial interest, the care group does do a good job of customizing these. Now, the problem was whether to put this into the bag or put it in the sulcus. That these things don't go into the bag. The bag is not enough to hold these implants. So we eventually decided, and after doing a bit of literature search and finding that they do well in the sulcus as well, we were able to position this to bridge that defect over there, and position it into the sulcus behind the iris at all points. So eventually, patient did well. There was a high-powered toric here, almost 2.5, 3 diopters of astigmatism, and the eye trace showed that we'd been able to correct astigmatism almost completely. And this patient eventually did well. I think there's one slide missing. I would have shown you the post-op outcome. I think it's kind of left out there for some reason. Anyway, so one way to do it, I usually do a single pass fourth row pupiloplasty. It does a great job, and especially in these aberrated corneas, you can actually do an excellent job of also minimizing what astigmatism does. And today I might even try, this was done about 2-3 years back, I would have tried to do a single pass fourth row and make it a spin hole pupiloplasty. Would have worked beautifully well as well. Now this is another patient who came to us. Fellow eye had a very nice trifocal implant done elsewhere. And now this was a very decentered pupil, needed a cataract surgery, somewhat like an ICE syndrome here. And on dilation, it looks much better, but if you saw that the pupil was really pulled to one side, so it's a decentered pupil. So we had to do something to improve the, and this patient obviously wanted a trifocal in the other eye. Now for that, to have the IOL well centered, and then to have the pupil well centered on the trifocal lens was a bit of a challenge. So we decided that we'll go ahead, of course, with the cataract surgery, which is again straightforward here. Rexis was trying to run out. We used the Bryan-Little's maneuver to pull it in and bring it back, and then managed to clear up the cataract, and then put in a trifocal lens there. Now we did a sphincterotomy on the other side, because we wanted to center this pupil basically. So there we've done a controlled kind of a sphincterotomy, and then using the virion, we were trying to see whether the IOL is well centered and the reflexes are there on the middle. And then we are doing a single pass fourth row pupiloplasty here to bridge that gap and make the pupil smaller. So this works amazingly well. It's very quick. And once that is done, now we have a slightly better pupil and more towards the central area. Then we do another small sphincterotomy to the other side. And eventually we are able to create a pupil which is now fairly well centered. Now on post-op, patient looks well. So you can see that the pupil is now fairly over the central area, and you can see the trifocal lens rings which are fairly well centered. Patient had a great outcome and did well. This was another trauma, firecracker injury. This lady had a big hyphema, eventually improved, but a big iridodialysis to repair. And we had to do both the cataract, and there was a bit of a subluxation in that area as well. So you can get the iris to one side while doing the cataract surgery using the iris hooks. And this patient gave history of having a pterygium surgery done. So the nasal conjunctiva where the big dialysis was a bit scarred. So we didn't want to dissect the conjunctiva in that area. We decided to go with Hoffman pockets. I'll just show you how that is done, and it saves the conjunctiva also for patients who might need glaucoma surgery in the future. It's a great idea to conserve the conjunctiva. So Hoffman pockets in some situations work quite well. So once we put in a CTR to stabilize the bag, and then put in the lens. Now once that is done, now we have to come with the task of doing the repair. So you can see that I'm going to create 3 pockets, in the small scratch incision at the limbus, and then dissect with a crescent into the subconjunctival sclera, and then pass the suture. Now this is a learning experience. This is again a surgery done a few years back. As I passed the needle through that iris, I was not holding it. Now that's a big blunder. And I have a big hyphema which has started from the root of the iris, and the iris also seems to have, the dialysis seems to have increased almost by half a clock hour over here. So now I'm going to use the modification which I felt would help us, because you should always either be holding the iris which requires surgery from the area right next to where you're going to pass the suture, or you can bring in a 26 gauge needle and do a railroad technique as I just showed you there. So what you can do is you can just bring this 26 gauge needle right where you want to pass the suture from the opposite side, and then pass the suture, kind of catch the iris where you want to pass the suture right there, and then through the Hoffman pocket and out. So once you've tied the knot under the Hoffman pocket, inside the pocket, you can just trim the suture and your conjunctiva remains absolutely fine. This is the second Hoffman pocket, and so on, a third Hoffman pocket. So 3 sutures passed, and you can see that now I'm ensuring that the iris is not pulled at all, and kind of capturing it into that 26 gauge needle which is ready to receive the suture. So eventually 3 Hoffman pockets do a great job there. And of course there are many ways to deal with this, but this worked well for me. Patient did well over here, and if you, it's got hung, some problem. I think audiovisual team, can you just check? Some problem with the connection.
Yeah. Gaurav, can we?
I think we can, I'm already done. I only had one more
Thank
video.
you
We can
very
go into
much.
discussion if you want.
Thank you very much, Dr. Gaurav, and because we are running short.